Welcome. Now, in the gastrology, the first thing we are going to discuss on the hepatology part, and then we will shift towards the intestine part. In the liver, the first thing we are going to discuss is the liver function test. You may have encountered many times the liver function test reports where you have the values of alkaline phosphate, SGOT, SGPT, and there are many other things. So, why they are there and how to interpret them? Let's have a basic idea before we go into more detailed concept of the hepatology clinical part. So, one of the first thing that you see is the SGOT and SGPT. SGOT and SGPT, these are the enzymes of transamination. SGOT is also referred as the AST. AST stands for aspartate transaminase. Whereas SGPT is also called as ALT, that is alanine transferase or transaminase, sorry. Alanine transaminase. So SGOT and SGPT, basically they are telling us about the hepatocellular function, means how the hepatocytes are working. So whenever they are deranged, basically they are indicating towards the hepatocellular injury. So they are for the hepatocellular injury. The second thing is alkaline phosphate. Although alkaline phosphate is very non-specific, it can be increased in many conditions because alkaline phosphate is produced in many different other tissues also. We will discuss them in a while. But if related to hepatology, alkaline phosphate is related to cholestasis. Cholestasis means if there is obstruction in the biliary flow, then that is called as cholestasis, and in that alkaline phosphate will be increased. Serum albumin and the prothrombin time. Now, serum albumin is a protein which is synthesized in the liver, and prothrombin time depends on the various clotting factors which are synthesized in the liver. So basically, albumin or the prothrombin time, basically they are indicating that how the synthesis function is happening in the liver. So they are indicative of the liver synthesis function. Then is the bilirubin. Bilirubin tells about the liver metabolism. So the SGOT, SGPT is for the hepatocellular injury, the albumin, prothrombin, they are for the how the liver synthetic function is happening. Now, what if the SGOT, SGPT is increased? Then we have to see that which enzyme is more increased, SGOT or SGPT. If SGOT is significantly increased, means if you see the ratio of SGOT, SGPT, SGOT is significantly increased than SGPT, the ratio is more than 2, then it is indicative of alcoholic liver disease. Or if the ratio is reverse, means SGPT is more increased than SGOT, then it is non-alcoholic liver disease. Non-alcoholic liver disease. But when the even in the non-alcoholic liver disease, if the disease is chronic and the patient develops cirrhosis because of let's say hepatitis infection, is infective hepatitis is a non-alcoholic liver disease. In that, initially the SGPT will be very high, but we know that hepatitis B or C, they can lead to cirrhosis of the liver. So if the cirrhosis develops, then the SGOT will be more, even in the non-alcoholic condition. If the SGOT, SGPT is deranged and SGOT is significantly increased, means the ratio is more than 5. Now, how it is possible that SGOT is so significantly increased? Because SGOT is just not found in the liver, SGOT is also found in the muscle. So, if there is rhabdomyolysis, the muscles are crushed, the crushed injury, in that case, from the muscles, a lot of SGOT will come out, and in that, the SGOT SGPT ratio may be more than 5. Normally, the SGOT SGPT values are 30-40. These are the normal cutoffs which are there. But if they are in thousands, if the SGOT SGPT they are more than 1,000, then there are only few causes. One, it can be fulminant hepatitis. It can be ischemic hepatitis. It can be autoimmune hepatitis. In the drug toxicity also, such as acetaminophen toxicity, or it can be Wilson disease. So there are very few causes which are there where the SGOT, SGPT can be more than thousands. There is one more value that we see in a report of liver function test, that is called as R ratio. R ratio is basically SGPT divided by alkaline phosphate. We know that alkaline phosphate is a marker of cholestasis and SGPT is a marker of hepatocellular injury. So if the ratio is more than 5, means SGPT is more. If the SGPT is more, it is indicative of hepatocellular injury. Hepatocellular injury. If the ratio is coming 2 to 5, then it is difficult to say whether it is hepatocellular or is it cholestasis. But if the ratio is less than 2, then it is more of cholestatic pattern. Cholestasis pattern. Right, so now we have understood how to interpret the SGOT, SGPT so far. Now coming to alkaline phosphate. Alkaline phosphate, I told you that it's just not produced in the liver, it is produced in several other tissues, and the mnemonic for that is BPL kit. So alkaline phosphate is found in the BPL kit. BPL kit, B stands for the bone, P stands for pregnancy. Instead of that, you can write placenta. Better word, placenta. L for liver, and kit is kidney and intestine. So BPL kit. What is there inside the BPL kit, or where is alkaline phosphate inside the BPL kit? That is bone, placenta, liver, kidney, intestine. These are the 5 organs which can produce alkaline phosphate. So alkaline phosphate is a marker of cholestasis. Alkaline phosphate is a marker of cholestasis, but it is not very specific. It is non-specific because it can be increased in several other injuries of the other tissues. So what are the other markers that we can use for cholestasis? The other markers that we can use, such as GGT, gamma glutamyl transferase. Gamma glutamyl transferase, it has a very higher sensitivity, very sensitive, and a very specific enzyme which is increased if there is a cholestasis, means there is a blockage in the biliary flow. The name of that marker is 5-nucleosidase. 5-nucleosidase. It is very specific. So we have several markers for cholestasis. Cholestasis means, for example, here is the liver, and we know that here is the biliary tree. So the bile is coming, the hepatocytes are making the bile, and ultimately it is coming in the biliary system. By any chance, if there is an obstruction in this flow, then it is called as cholestasis, and for that we can use the alkaline phosphate, GGT, or the 5-nucleosidase. There is one more we can add, that is lipoprotein X. Lipoprotein X is also marker of cholestasis, which in short sometimes written as LPX. Now, by chance, let's say you are looking at a report of the liver function test, alkaline phosphate is increased. Now, we know that alkaline phosphate is a non-specific marker of cholestasis. So, we have to identify whether it is because of cholestasis or because of something else. So, if the alkaline phosphate is more, check for GGT, gamma glutamyl transferase. If a gamma glutamyl transferase is normal, then it is not cholestasis. It may be the other than the liver disease. It's non-hepatic cause. Non-hepatic. But if the GGT is also increased, alkaline phosphate is increased and GGT is also increased, then yes, it is going towards cholestasis. Now, when it comes to cholestasis, where the cholestasis is happening, means cholestasis means there is a problem in the flow of the bile. And where is the obstruction? Is it the obstruction in the common biliary duct, CBD? Means, for example, is there any stone or tumor which is obstructing the flow here? This is basically is an extrahepatic obstruction. It's an extrahepatic obstruction, and in that case, what is going to happen is the bile will not be able to bile will be coming till this point. It will not be able to flow forward. So the bile is going to accumulate here and here, here and here, and this biliary tree will be distended. Will be distended like this. So whenever alkaline phosphate is increased, GGT is increased, you are saying it's a stasis. And if the stasis is happening extrahepatic, then there is going to be the distended biliary duct. So you have to do that. The duct is distended or non-distended. If it is distended, means the obstruction is outside the liver. It may be because of some gallbladder stone or maybe because of tumor. So because of that, the biliary duct has distended. But if the biliary duct is non-distended, If the biliary duct is non-distended, then where is the obstruction? The obstruction then in that case, it is going to be the intraluminal obstruction, such as, for example, primary sclerosing cholangitis. In that case, in the lumen, there is sclerosis in the lumen of the biliary duct. So when you will do the USG, you will not find that the biliary duct is distended, but there is obstruction is there, right? So if the biliary duct is non-distended, then the causes can be drugs, sepsis, primary biliary cirrhosis, or primary sclerosing cholangitis. So these are the causes. So this is how we have to interpret the alkaline phosphate. Let's make it simple again. If the alkaline phosphate is more, look, GGT is normal or not. If the GGT is normal, it's not related to liver then. If the GGT is more, yes, it is liver. There is obstruction. You have to find where is the obstruction. Look at the biliary duct. If the biliary ducts are distended, means there is a distal obstruction. That is why it is distended, right? Then it can be stone or tumor. But if the biliary ducts are non-distended, then it may be because of drugs, primary biliary cirrhosis, primary sclerosing cholangitis. These are the things that can be there, right? Now, there are some conditions where the alkaline phosphate can be low. Alkaline phosphate can be low in hypothyroidism. It can be low in pernicious anemia, or it can be low in zinc deficiency. Alkaline phosphate can be low in these conditions, and because it's a combination of three, so it's a potential all except quotient. Now coming to the important concept of bilirubin. From where this bilirubin is coming, what is this conjugated, what is unconjugated, right? What is direct, what is indirect bilirubin? So before I go forward, I want to make few things very clear to you here itself. See, we have two types of bilirubin: water insoluble bilirubin and water soluble bilirubin. Water insoluble is also called as indirect bilirubin, whereas water soluble is called as direct bilirubin. This indirect is also called as unconjugated bilirubin, and this is called as conjugated. So when it comes to bilirubin, there are two types: water insoluble and water soluble. Why it is called water insoluble is also called as unconjugated, or why water soluble is called as conjugated, you will understand in a while. Now, our primary focus is to understand what the word bilirubin means to us, from where this bilirubin is coming to our body. So when the RBC completes its lifespan, the lifespan of the RBC is somewhere around 100 to 120 days. Once it is completed, this RBC will be destroyed, and mainly the destruction of the RBC is going to occur in the spleen. So the breakdown of the RBC will happen. When the RBC will break down, the hemoglobin will come out. The hemoglobin will further break down. The hemoglobin will break down into heme and globin. Heme plus globin. Now, globin is a protein. It will be reused. So right now, our concern is not globin, but our concern is heme. If you further break down the heme, we are going to get a molecule called as biliverdin. Biliverdin. And this biliverdin can convert into a molecule that is called as bilirubin. And this bilirubin, which is synthesized in the spleen, this is water insoluble bilirubin. Water insoluble. So from where the water insoluble bilirubin is coming, when the breakdown of the RBC happens, mainly in the spleen, we are going to generate the water insoluble bilirubin. This water insoluble bilirubin is also called as the indirect bilirubin, or also called as the unconjugated bilirubin. Now, the point is, this bilirubin is not very important for us. We want to throw out the bilirubin from our body, and the excretion can happen from the kidney. The kidney can only excrete water soluble substance, and right now you can see that this bilirubin is water insoluble. So how to excrete this water insoluble bilirubin? First, we have to make it water soluble. Then only it can be thrown out of the body. Now, the conversion of this water insoluble bilirubin to water soluble bilirubin can only occur in the liver. So now the spleen is going to send this unconjugated bilirubin towards the liver. But how? They require a transporter, and the transporter is going to be albumin. So with the help of albumin, the unconjugated bilirubin means the water insoluble bilirubin and albumin will club together and will go towards the liver. When they will reach in the liver, this is the unconjugated bilirubin. The unconjugated bilirubin has reached in the liver. In the liver, we have one special enzyme. That in special enzyme is going to add that is called as the glucouronyl transferase. That is going to add the uronyl group. So on the unconjugated bilirubin, there is one enzyme that is going to work. That is glucouronyl transferase, and that is going to transfer the uronyl group, and that will convert the water insoluble bilirubin into water soluble bilirubin. This water soluble bilirubin is also called as conjugated bilirubin or the direct bilirubin. Now, why it is called as conjugated? Because on the unconjugated bilirubin, which was water insoluble, you have conjugated a molecule, that is glucouronyl group. Once you will conjugate this group, the water insoluble substance converts into water soluble substance. So because of conjugation, we are making the water soluble bilirubin. So that water soluble is also called as conjugated bilirubin or the direct bilirubin. Now our purpose is done. We want to throw out this bilirubin and we have converted into water soluble substance. It can be easily thrown out via the kidneys. But how it will reach to the kidney? Let's understand. Now this water soluble bilirubin will come out from the liver. This water soluble bilirubin will try to come out from the liver in the biliary system. Now to come out from the liver, it requires a protein called as MRP2. With the help of this MRP2, this conjugated bilirubin will come out and it will come in the bile, and in fact it will give the color to the bile also. This bilirubin is a dark yellow colored substance, and that is why the bile is also dark yellow. And because the bilirubin is giving the color to the bile, so bilirubin is also called as bile pigment. It's called as bile pigment because it is giving color to the bile. Now this conjugated bilirubin has came in the intestine. It has came in the intestine. In the intestine, we have the intestinal bacteria. These intestinal bacteria, they are going to further break down this conjugated bilirubin, and they will make a substance called as urobilinogen. Urobilinogen. This urobilinogen can convert into stercobilinogen, and the stercobilinogen can come in the stool, and that is why the color of the stool is also yellow, because of this substance stercobilinogen. Now meanwhile, when all these processes happening, the urobilinogen converting into stercobilinogen, and that is coming in the stool, meanwhile what happens is some amount of conjugated bilirubin gets absorbed from the intestine and it comes in the blood. So in our blood, we are having some conjugated bilirubin because it has been absorbed directly. Plus, whatever is the urobilinogen that is made, out of 80, whatever is the urobilinogen, out of that only 80% will convert into stercobilinogen. The remaining 20%, out of that, some will come in the filtered in the kidney and will come in the urine, the urobilinogen. And that is why the color of the urine is also light yellow, and some urobilinogen will be absorbed and will go towards the liver back. And all this conjugated bilirubin and urobilinogen, they will travel via the portal vein with the help of a special channel, that is ATP channels B1, B3. The conjugated bilirubin will reach back in the liver. So this is how the bilirubin is getting excreted. Let's understand it again here. The RBC breakdown happened, the water insoluble bilirubin was made. I want to throw out this bilirubin, so I have to make it water soluble. This process can occur in the liver with the help of enzyme glucouronyl transferase. We are going to add some substance, so this water insoluble substance will convert into water soluble, and that is called as the conjugated bilirubin. It will come out from the liver with the help of MRP2, and then it will come in the intestine. The conjugated bilirubin can convert into urobilinogen or stercobilinogen and can be thrown out in the stool. Some amount will get absorbed and will go back to the liver. Now, in that entire process of the bilirubin metabolism, sometimes there can be some inborn errors. And because of that, if by any chance, if this metabolism is not happening properly in the body, the bilirubin can accumulate, the bilirubin can increase, and that is called as hereditary hyperbilirubinemia, because that disease is going to be by birth. For example, this enzyme, you can easily understand that this enzyme is very important to convert the water insoluble bilirubin into water soluble, means to unconjugated to conjugated. If this enzyme is not there, the unconjugated bilirubin will not be able to convert, and that is going to accumulate in the body, and that is called as unconjugated hyperbilirubinemia. So if this enzyme is not there, if there is a mild deficiency, if there is deficiency of UDP, glucouranosyl transferase, that will lead to increase in the unconjugated bilirubin. If there is a mild deficiency, this is called as Gilbert syndrome. If there is moderate deficiency, that is called as the Crigler-Najjar type 2. And if there is a severe deficiency, that is called as Crigler-Najjar type 1. For the Gilbert syndrome, we can give phenobarbital, and for the Crigler-Najjar, you have to go for liver transplant. Right? So, unconjugated bilirubin can increase in the Gilbert or Crigler-Najjar because the enzyme deficiency is there. Now, I will tell you some more problems. You just have to tell me that because of that problem, which bilirubin is going to increase, the unconjugated or conjugated. Let's understand it here. If I say that there is a child and he is having problem in MRP2, if the MRP2 protein is not there, which was helping the conjugated bilirubin to come out and go out from the body, if this MRP2 is not working properly, then the conjugated bilirubin cannot come out, and the conjugated bilirubin will increase, right? If the MRP2 is having a problem, the conjugated bilirubin will increase. You answer me one more question. Here is a channel, that is the ATP1B1B3 channel, that is taking the bilirubin in the liver back. If this channel is not working, then which bilirubin will not be able to go back to the liver? Which bilirubin is going via these ATP channels? Which bilirubin? The conjugated bilirubin. If the ATP channels are not working, the conjugated bilirubin will not go inside, and the conjugated bilirubin will increase in the blood. So there are two conditions where the conjugated bilirubin can increase. If there is a problem in the MRP2, the conjugated bilirubin cannot come out from the liver and will increase. And if there is a problem in the ATP channels, again the conjugated bilirubin reuptake will not happen, and the conjugated bilirubin can build up. So, if there is a defect in the MRP2, there is going to be decrease in the secretion of the conjugated bilirubin in the biliary tract. From the liver, the bilirubin will not be able to come in the biliary tract, and that will lead to increase in the conjugated bilirubin. This is referred as the Dublin-Johnson syndrome. Dublin-Johnson syndrome. The second, just now I have told you, if there is a problem in the ATP B1, B3, then the reuptake of the conjugated bilirubin will not happen. There is going to be decrease in the reuptake of the conjugated bilirubin, that leads to increase in the conjugated bilirubin, and this is called as Rotar syndrome. So, if there is a problem in the MRP2 or ATP channels, the conjugated bilirubin will increase. How we are going to make a diagnosis? Let's say a lab report comes to you, and in that there is a child, he is having increase in the conjugated bilirubin by birth. Two options you have to rule out, whether it is conjugated or is it whether it is Dublin-Johnson or whether it is the Rotar syndrome. How we are going to make a diagnosis? We are going to give a substance to the boy, to the child, that is bromosulfonane. When you will give this bromosulfonane goes in the intestine. We are going to give this drug to the child. This will be absorbed in the intestine. It will come in the liver. Once it comes in the liver, bromosulfonane is a molecule which can be thrown out from the liver with the help of MRP2. So, we are going to give this substance, and we will see that whether the bromosulfonane is able to come out from the liver or not, whether the clearance of the bromosulfonane is happening or not from the liver, because bromosulfonane can only come out from the liver with the help of MRP2. If the MRP2 is not working, the bromosulfonane cannot come out, and if the MRP2 is working, it will come out. So we are going to do a clearance test, bromosulfonane clearance test. So if there is Dublin-Johnson syndrome, means there is a problem in the MRP2, there is no clearance. There is decrease or no clearance. Whereas if the patient is having rotar syndrome, the clearance will be there. The clearance will happen. So this is how we can easily differentiate whether it is the Dublin-Johnson or the rotar syndrome. Recently a question came. Before I go to that question, I will just tell you one simple mnemonic. See, we have discussed 4 diseases. First, Gilbert syndrome, then Crigler-Najjar, Dublin-Johnson, and rotar. In the first 2, unconjugated bilirubin is going to increase, and in these 2, conjugated bilirubin will increase. So these are the unconjugated hyperbilirubinemias and these are conjugated hyperbilirubinemia. So this was one question that has came in your exam. How we are going to remember that in the exam? See, you can use one simple mnemonic that we have discussed even in the biochemistry also, if you remember. For example, if you take a roti, if you take one more roti and you join them, means you are going to conjugate them. If you conjugate the roti plus one more roti, this will be referred as what? This will be like this. This is referred as double roti. Double roti. So, in which condition the conjugated bilirubin is going to increase? The conjugated bilirubin is going to increase during the double roti. Double roti means Dublin-Johnson and rotar syndrome. So when you make the double roti, you have to do conjugation. So in double roti, which bilirubin is going to increase? The conjugated bilirubin. Dublin-Johnson, rotar, conjugated bilirubin, double roti. Okay. Now, in the gynecology and obstetric gynecology, you have discussed that during the first few days of the life, we all develop the physiological jaundice. Why we develop physiological jaundice? The reason is, see, the unconjugated bilirubin converts into conjugated bilirubin in the liver with the help of enzyme UDP glucouranosyl transferase. When the child is going to take the breast milk has a property that for some time it can decrease the activity of UDP glucouranosyl transferase. The UDP glucouranosyl transferase enzyme will work less because of breast milk. If this enzyme is not working properly, then the unconjugated bilirubin will not be able to convert. So there is going to be mild increase in the unconjugated bilirubin. And the child will have a mild jaundice. Right? Now, there is no need to stop breastfeeding. It is just a transient thing that is going to happen in the initial first few days of the life. Because of the breast milk, there can be decrease in the activity of this enzyme. So unconjugated bilirubin will increase. But over time, the liver will overcome with this situation and will be habitual to the breast milk. Now, there is one more condition, that is the Lucey-Driscoll syndrome. In that, what happens is, this is a familial condition where in all the family members, there is going to be decrease in the activity of this enzyme. See, sometimes what happens is, due to maternal serum, there is going to be this enzyme activity will decrease. If because of maternal serum, the UDP glucouranosyl enzyme transferase will not work, again the unconjugated bilirubin will increase. So if you look at the breast milk jaundice or the neonatal Lucey-Driscoll syndrome, in both of them the enzyme is not working. In the breast milk jaundice, it was because of breast milk. The enzyme is not working properly. If this enzyme is not working properly, it's because of the maternal serum. Then this is called as the Lucey-Driscoll syndrome. So Lucey-Driscoll or the breast milk jaundice is more or less same. The main pathogenesis is exactly same. The only thing is the trigger. Is the breast milk is creating the problem? Breast milk jaundice. If the maternal serum is creating the problem, Lucey-Driscoll syndrome. What is the normal total bilirubin? Normally, the total bilirubin is up to 1.2 milligram per deciliter. Out of that, 0.9 milligram per deciliter will be unconjugated. So mostly the bilirubin which we are having is water insoluble. The water soluble bilirubin will be less. The reason is very simple, because if the thing has already been water soluble, it will be thrown out from the body. So we have less water soluble bilirubin will be present in the blood, because water soluble can be easily thrown out from the body. So only thing that you are going to get is the water insoluble bilirubin more in the blood, right? Okay. Now, we know that whenever the bilirubin increases, that will lead to jaundice, right? The yellowish discoloration of the body. Now, the causes of increased level of bilirubin, why we have discussed one cause already, the hereditary hyperbilirubinemia, the Gilbert syndrome, the Kigler-Najjar, the Dublin-Johnson-Rota syndrome, we have discussed. Now, there are some other causes that can lead to jaundice. Now, the causes of the jaundice can be divided into three categories. Let's understand this circulation that already we are familiar with, because we know that the bilirubin is basically made in the spleen by the breakdown of the RBCs. Breakdown of the RBC happens, the unconjugated bilirubin is made. This unconjugated bilirubin, for example, here is the unconjugated bilirubin. This unconjugated bilirubin comes in the liver. Then it gets converted into conjugated bilirubin. And then the conjugated bilirubin will be coming in the intestine. And then conjugated bilirubin can convert into urobilinogen or stercobilinogen, and these molecules will come, the stercobilinogen will come in the stool, that will make the stool color yellow. Urobilinogen will make the color of urine yellow. Likewise, the things will happen, right? And here in this diagram itself, I want to make you one point very clear before I go to the further part of discussion, that in the urine, there are two things that can come as far as the bilirubin is concerned. One we have already discussed, that is urobilinogen, that can come in the urine. But now I want to ask you one question. If I say that the bilirubin is coming in the urine, what do you think? Which bilirubin has a potency to come in the urine? Unconjugated or conjugated? Which bilirubin can come in the urine? Yes, it is conjugated bilirubin, because that is water soluble. That is water soluble, right? So there are two things that can come in the urine: conjugated bilirubin and urobilinogen. Keep this thing in your mind, and this table will be very easy. If you don't keep this thing in the mind, then it will be difficult, right? Why these things can come in the urine? Because they are water soluble. Conjugated bilirubin, yes. Urobilinogen, yes. It can come in the urine, right? Okay. So when it comes to jaundice, whenever a patient of jaundice is coming to us, we have to find where is the problem. The problem is before the liver, means in the spleen or somewhere in that area, that is called as the prehepatic cause of the jaundice. If the problem is in the liver, that is called as the hepatic cause of jaundice. And if the problem is after the liver, then it is called as the post-hepatic cause of jaundice. So first, let's talk about the prehepatic cause. Then we will go one by one. Prehepatic cause, for example, what can be a problem in the spleen? So there can be more bilirubin will be formed. What is happening in the spleen? Hemolysis. If there is more hemolysis is happening, the RBC breakdown is happening very fast, a lot of bilirubin will come. Now you tell me, which bilirubin will come? If there is more hemolysis is happening, which bilirubin will come? Unconjugated bilirubin, right? So one cause of prehepatic jaundice is going to be the hemolytic anemia. Now, in the hemolytic anemia, which type of bilirubin is going to increase in the blood? Which hemoglobin will increase in the blood? Unconjugated or conjugated? Yes, it is unconjugated bilirubin will increase. Unconjugated bilirubin will be more. You tell me one answer that, can unconjugated bilirubin comes in the urine? Can unconjugated bilirubin come in the urine? No. Unconjugated bilirubin can't come in the urine. So now this unconjugated bilirubin, where it will go? Unconjugated bilirubin will reach in the liver. Once it will reach in the liver, it will get converted into conjugated bilirubin, because there is no problem in the liver, right? It can convert into conjugated, and then conjugated bilirubin will come in the urine. Conjugated bilirubin will convert into urobilinogen, stercobilinogen, that will come in the urine and stool. So the question is, in the prehepatic cause of jaundice, in the urine, what will come? Bilirubin, urobilinogen, or both? And you are saying that in prehepatic, which bilirubin has increased? Unconjugated. Can unconjugated bilirubin comes in the urine? No. There is no bilirubin in the urine. But urobilinogen, yes, it will be there. Now you know that alkaline phosphate, SGOT, SGPT, they are related to what? They are related to the liver. Alkaline phosphate is related to the obstruction, and SGOT, SGPT is related to the liver. Is there any problem in the liver? No, in the prehepatic cause, there is no problem in the liver. Is there any problem in the flow of the bile? No. So, the alkaline phosphate, normal. SGOT, SGPT, normal. And because there is no problem in the conversion of the unconjugated to conjugated, there is no problem to conjugate into stercobilin, urobilin, they are going to be formed as normal, right? And they will come in the urine as normal. So, the color of the urine will be normal. There is no problem with the color. So, in the prehepatic cause such as hemolysis, means the hemolytic anemias. In the hemolytic anemias, there will be increase in the unconjugated bilirubin, and in the how we are going to confirm that? For example, a patient is coming to us, he is having jaundice, his skin is completely yellow, right? But now, whether it is unconjugated bilirubin increase or conjugated increase, the skin turns yellow, right? Now we have to find that which bilirubin is increasing. So we will take the urine and we'll see in the urine whether the bilirubin is there or not there. If it is not there, means the unconjugated has increased. And what we'll see in the urine only and only is the urobilinogen, right? Now comes the let's first do the post-hepatic. That will be relatively easy for us. The post-hepatic. First, I will explain the post-hepatic here, and then you will answer the things. See, we know that in the urine, there are two things that can come. One is the urobilinogen, and the second thing that can come is the conjugated bilirubin. If it is very much high, the conjugated bilirubin also have a chance to come in the urine. There are two things that can come in the urine. One is urobilinogen and conjugated. Conjugated bilirubin only comes if it is very high. If it is normal, it will not come, right? So, now we are having a situation that this is the biliary tree, the biliary duct, the common bile duct, and like this. For example, there is a gallstone which has been impacted here. There is a gallstone. Now, if there is a gallstone, this will come under which category? Post-hepatic, because the problem is after the liver. So, for example, there is a gallstone. I am trying to explain you how the post-hepatic patient will present. Now, if the gallstone is there, now what is going to happen is the RBC breakdown will happen, the unconjugated bilirubin will reach in the liver, it will get converted into the conjugated. Now, you tell me that, can the conjugated bilirubin come out from the biliary tree? No. If the conjugated bilirubin cannot come out, the conjugated bilirubin will increase. And now the conjugated bilirubin will come in the blood directly. If the conjugated bilirubin will come in the blood, can the conjugated bilirubin comes in the urine? Yes. Conjugated bilirubin is water-soluble substance. The conjugated bilirubin will start coming in the urine. The conjugated bilirubin will come in the urine and the color of the urine will be yellow. But now what is going to happen is, because you are saying that the conjugated bilirubin cannot come in the bile, means there is no bile is coming in the intestine, means no bile, means no urobilinogen, no stercobilinogen. If there is no stercobilinogen, what will be the color of the stool? Completely yellow or white? Yes, it is going to be white, the clay color stool, because there is no stercobilinogen and there is going to be no urobilinogen. No urobilinogen, no stercobilinogen. There is only increase in the conjugated bilirubin that is directly coming in the urine, and that is why the color of urine is not changing much. Right? Normally the color of the urine can be because of urobilinogen or conjugated bilirubin. Both have the same color. But in this patient, the urobilinogen and stercobilinogen is not there. So the stool will be completely clay colored, white colored stool, but urobilinogen will not be coming in the urine. But what can come in the urine is conjugated bilirubin. This is called as the post-hepatic jaundice, right? So in the post-hepatic cause of the jaundice, which type of bilirubin increases? Conjugated bilirubin. Conjugated bilirubin. The bilirubin will be there in the urine. Yes, it will be there. Urobilinogen will be there. No, it will not be there. It will not be there. ALP, alkaline phosphate, is a marker of bile obstruction. Is there any biliary obstruction? Yes, alkaline phosphate will increase. SGOT, SGPT is a marker of hepatocellular injury. Is there any problem in the hepatocytes in the post-hepatic cause? No, there is no problem in the liver. The problem was in the biliary duct. So SGOT, SGPT normal. What was the color of the urine? Normal, yellow. Normal yellow color. And it is because of, it is due to conjugated bilirubin in the urine. It is due to conjugated bilirubin in the urine. But the most important, what will be the color of stool in the post-hepatic? Clay colored. Clay colored. White. Clay colored stool. It's a very important MCQ. Clear color stool, post-hepatic cause. Now comes the hepatic cause of jaundice, hepatic cause of increased level of bilirubin. Now, hepatic cause such as the viral hepatitis, drugs, cirrhosis, these are the hepatic causes. Now, for example, let's understand in this example. There is hepatitis is happening in the patient, and there is, because of hepatitis, there is some inflammation in the hepatocytes which are there. Now, what is going to happen is, if there is some problem in the liver, see what happens, the RBC breakdown will happen, the unconjugated bilirubin will be produced, the unconjugated bilirubin will come in the liver. Till this point, there is no problem. Now, the unconjugated bilirubin will come here because of the breakdown of the RBC. Now, there is a problem in the liver itself. There is some breakdown of the RBC will happen in the liver also. And the unconjugated bilirubin will be produced. There is more unconjugated bilirubin. And this unconjugated bilirubin, to some extent, can convert into conjugated bilirubin. Conjugated bilirubin. So, hepatic causes, in the hepatic causes, there can be increased in the unconjugated bilirubin, there can be increased in the conjugated bilirubin, both. So, in the causes of, when it comes to the hepatic causes, in the hepatic causes, just remember this thing very importantly, that we can have increased level of unconjugated bilirubin and conjugated bilirubin, both can be increased. Conjugated, unconjugated, both can be increased. And I told you that if the conjugated bilirubin is more, it can come in the urine. So in the hepatic cause, in the urine bilirubin, yes, you can be there. It can be there. And because there is no obstruction, now you will understand it here. The conjugated bilirubin is there. There is no obstruction. The conjugated bilirubin will come here, will convert into urobilinogen, will convert into stercobilinogen, and they will come in the urine stool. So there is no problem with the urobilinogen, stercobilinogen. Yes, they are going to be formed and they will be coming in the urine stool. So the color of the urine stool, they are going to be normal, means yellow, means dark. Normal yellow, dark. The reason they are going to be dark, because there is more bilirubin is there. So obviously they are going to be dark, relatively more dark. What is going to happen with ALP? Now you will answer this question. In the alkaline, if there is hepatic cause, what is going to happen with ALP? What is going to happen with SGOT, SGPT? First tell me SGOT, SGPT. SGOT, SGPT is a marker of hepatocellular injury. And in the hepatic cause, yes, SGOT, SGPT is increased. Is there any obstruction? No. More or less, no. So alkaline phosphate will not be increased. It's going to be normal. Instead of minus, I will write normal. That will make more sense. So when it comes to hepatic, pre-hepatic, post-hepatic, in the pre-hepatic, there is going to be hemolysis. Not very important. Hepatic, there is going to be the inflammation in the hepatocytes. There will be increase in the unconjugated as well as conjugated bilirubin both. So the conjugated bilirubin will be coming in the urine, as well as the urine will be dark, stool will be dark. But in the post-hepatic, means there is an obstruction in the biliary duct. The alkaline phosphate will increase. And because there is an obstruction, the bile is not coming in the intestine. The bile will means the bilirubin is not able to come. Means in that case, the color of the stool is going to be white, the clay colored stool. And can you tell me, in the post-hepatic, the stool color is, we understand that it is a clay colored. But why the color of the urine is still yellow? Why it is not completely white? Because which substance is coming in the urine in that case? Conjugated bilirubin. The conjugated bilirubin is coming, and that is leading to the yellow color, right? So this is the difference between the pre-hepatic, hepatic, and post-hepatic, right? So we have discussed overall the basic idea behind the liver function test. So if I just summarize the things here, SGOT, that is also called as aspartate transaminase. SGPT, that is also called as alanine transaminase. Whenever we talk about them, they are the marker of hepatocellular injury. Alkaline phosphate is a marker of cholestasis. When the SGOT, SGPT is more, you have to see which is more. If the SGOT is twice or more than that, it is alcoholic liver disease. If the SGPT is more than the SGOT, then it is non-alcoholic liver disease. Then we have discussed something called as R ratio. The formula of R ratio can be asked. SGPT divided by alkaline phosphate. Then can you tell me that in rhabdomyolysis, or in fact I can ask a question from biochemistry. SGOT is found in 3 tissues. Can you tell me the 3 tissues where you have SGOT? One is obviously is the liver. Second is cardiac muscles. And third is skeletal muscle. SGOT is found in 3 places. That is why SGOT can be increased if there is a problem in the liver, hepatitis, cardiac muscle problems such as myocardial infarction, SGOT can be increased. Skeletal muscle problems such as rhabdomyolysis, SGOT can be increased. So SGOT can be increased if there is any injury in liver, cardiac muscle or skeletal muscle. Then we have discussed that alkaline phosphate, it is found in 5 tissues. Can you tell me the mnemonic? Alkaline phosphate is found in which kit? BPL kit. Bone, placenta, kidney, liver and intestine. Bone, placenta, liver, kidney, intestine, alkaline phosphate. Then we have discussed there are various other markers of cholestasis. Other markers of cholestasis, GGT, GGT, 5 nucleosidase and lipoprotein X. The last, very important, clay colored stool. It is seen in which condition? Clay colored stool, it is seen in which condition? Pre-hepatic, hepatic, post-hepatic. Yes, it is seen in post-hepatic jaundice. Post-hepatic causes. And yes, we have discussed in which condition there is going to be increase in the conjugated bilirubin. Conjugated bilirubin will be increased in Dublin-Johnson, Rotar, or Krigler-Najar-Gilbert. Yes, it is conjugation. Conjugation means double rotation. Dublin-Johnson and Rotar. Dublin-Johnson and Rotar. Right? So these are the points to be remembered when it comes to the basic idea behind the liver function test. Right? Thank you.